Sure, we had everything ready to go for this morning. Welcome to our second sports medicine grand rounds of the year, stress fracture management in the female athlete, a multidisciplinary approach. For those of you that don't know me, my name is Diana Toto. I'm the Director of Sports Medicine and Business Development here at RWJBarnabas Health. I spend a lot of my time at Cooperman Barnabas Medical Center. I also oversee the Matthew J. Morahan III Health Assessment Center for Athletes. I want to thank all of you for coming on today. And hopefully you are gearing up for some summer weather, or your sports seasons are coming to an end and you're getting maybe a little relaxation. We're really excited to have our panel here with us today to talk about the female athlete and to have Dr. Ashraf as our keynote. I'm just gonna, remind you of a few housekeeping items. This session does offer one CEU for athletic trainers and one CME for physicians. So we will be running attendance after the session. Please stay on for the full 60 minutes to receive your credit. We will also send you a survey link within the next 7 to 10 days to redeem your credit. So just keep an eye out for that in your emails. All right, so I'm just going to jump right into introducing our panel here. Our supportive multidisciplinary panel. We're going to start with Dr. Jason Krystofiak. Dr. Krystofiak is our Medical Director of Sports Medicine here at Cooperman Barnabas. He's also our Medical Director of the Morahan Health Assessment Center for Athletes. He is Assistant Team Physician for Rutgers Athletics, and he is Clinical Assistant Professor for Rutgers RWJ Med School. Good morning, Dr. K.
Good morning.
You're at the stadium, I see. Next, we have Dr. Pete Economou. Dr. Pete is the Director of Behavioral Health and Wellness for Rutgers University Athletics and also Rutgers University Associate Professor for the Graduate School of Applied and Professional Psychology. Good morning, Dr. Pete.
Good morning, everybody.
We also have Jenn Stautz. Jenn is the Assistant Athletic Trainer for Women's Gymnastics for Rutgers University Athletics. Good morning, Jenn.
Good morning.
And we have Katie Salomone, Director of Sports Nutrition for Rutgers University Athletics as well. Good morning, Katie.
Good morning.
And finally, we have our keynote speaker. I have the privilege of working with Dr. Ashraf week to week. Dr. Ashraf is an assistant professor of physical medicine rehabilitation and a fellowship-trained board-certified physiatrist at Rutgers RWJ Med School, where she specializes in sports medicine. She has previously worked with athletes from the NBA, NHL, and USA Women's Soccer team, as well as NCAA Division I athletes. She is currently the team physician for New Jersey City University and provides physician coverage for several collegiate and high school athletic teams in Essex County. And she's also a spine interventional specialist and a rock star. So Dr. Ashraf, we're really excited to have you. The floor is yours.
Thank you, Diana. Can you hear me all right?
Yes.
All right. Thank you to everyone attending virtually. Happy Summer Friday. So today we're going to be talking about stress fractures. And with this topic, we will try. All right. So with this topic, we're going to be trying to deconstruct a very complex issue into easy to digest bites. And we're going to review for the healthcare practitioner today how to best evaluate a female athlete, even if they're coming as a first pass with an undiagnosed chief complaint to your setting. And if you are planning as a practitioner to refer this issue out, we're still going to review, what can be done on the initial eval. What does the evidence show are the risks for female athletes in particular, and how important a multidisciplinary team approach and bringing in their specialists in to work together to treat these complex layers of bone stress injuries when they present is needed, okay? Slide. I want to review a high yield case, and then I want to also discuss some screening tools and diagnostic imaging that we can utilize when looking at overall bone health, fracture rehabilitation, return to sport, nutrition, behavioral health, and reproductive health. We're going to also pull from our expert panel with us this morning. And if you have any questions or comments, if you could just leave them in the sidebar, and then we'll be sure to leave ample time at the end to address any questions that arise. Slide. Next slide. All right, so we had a third-year female cross-country athlete present. There was no rapid change in her training regimen, but she did complain of left buttock non-radiating pain that she described as a tightness that would not resolve with stretching. It was present for about 2 weeks and came on with her running activities. The year prior, she had a left proximal hamstring tendon injury that was rehabbed. Upon further questioning, she had no other significant medical or surgical history. Her menarche started at age 14, and she had reported in the past 12 months 6 menstrual cycles. On average, she was running about 50 to 55 miles per week. Again, no rapid change in what she was doing, no drastic change in her training. However, she had spent a large portion of the summer and the fall logging large volumes of miles every week, both indoor and outdoor. Slide. I think go back one, physical exam. So she presented on exam with vitals that were very typical of an endurance athlete, but there was the addition of an underweight body mass index. She had positive exam findings for Faber and single leg hop. This is what's demonstrated here in the photo, and that gave her her classic buttock pain. On further examination, she had a normal lumbar spine neurological exam, and she had no pain at the insertion of her conjoint hamstring tendon, and she had negative hamstring tendon exam findings. Slide. So plain radiographs, this one here being the AP of the pelvis, were unremarkable in the office that first day. As we can see on the imaging, the L5-S1 disc, the pelvic ring, the femoroacetabular joint, they all look pretty normal on initial survey. Slide. So the athlete was giving a work-in diagnosis of possible sacroiliac ligament sprain. This can occur commonly with trunk rotation during sports activities. Her training regimen was modified, and the trainer was notified to work on physical therapy stretching, lumbopelvic strengthening, and some other additional treatments. And after 1 week, she reported that she was feeling much better, so she was permitted to return to ground running. However, right away, her pain returned with intensity, and it was making it very difficult for her to even ambulate independently. So she came back into the office with the trainer, and we gave her crutches for toe touch weight bearing, and we decided that advanced imaging was warranted. Slide. Great. So the scroll function on these MRIs is letting us down this morning, but as you can see on the static images, the patient is experiencing a sacral stress fracture on the left side of her pelvis. The giveaway sign is that large amount of edema on the T1 in the middle photo, showing that on the T2s on the left and the right, there is a non-displaced cortical break. The sign of edema without the fracture line would be considered a stress reaction only. And here we really want to utilize the coronal view, especially for the sacral fractures, to ensure we don't miss anything. The nice part about having the MRI is that you can also evaluate for possible other things on your differential in the low back buttock pain. So for example, a lumbar spondylolysis or a pars defect, which can be very common in young endurance athletes, would present differently. And here we want to really focus on number one, the edema on the T1, and then possible cortical break, which we can evaluate really well with the T2. Next slide. So there are a variety of things that you can utilize in your office. Obviously, the easiest to access would be plain films on the first eval. The downside of this, however, is the low sensitivity of radiographs. So these are best utilized to see healing stages for a chronic fracture. Previously, triple phrase bone scan would be utilized more often. This is quite sensitive, but I think that this has been sort of moved away in the orthopedic field, and it's mostly reserved now, I would say, for the oncologic world. For a stress fracture on a Tech 99, you'd want to see positive uptake in all three phases. So our gold standard imaging is the MRI with the high resolution abilities. This is both high for sensitivity and specificity, and we're really looking, keeping our eyes peeled for that edema. Of course, a CT scan in a reproductive age athlete or young woman is not preferred if there are alternatives. And the alternative could be a bone scan because the radiation is a lot lower than for a CAT scan. Okay, next slide. Okay, so when we look at sacral stress fractures and look at the numbers, the tibia now has become the main culprit, and its high prevalence is it's thought to be due to the increasing popularity of long distance and marathon running. The musculoskeletal physician can employ a team of additional practitioners here to manage these complex layers when they see a bone stress injury in their office. We want to start thinking about the nutrition, the behavioral health components that may be causing low bone mineral density. We want to look at the athletic training regimen and also preserving this young woman's reproductive health. What I want to do is kind of go over some of the central tenets to what does the evidence say about bone stress injuries and really hit on the most salient points. If you are the initial examining doctor, how to maximize the goals of the visit. And then we're going to hear from our panel to talk about how do we each break down all these complex layers when we take a team approach. Next slide. The female athlete triad is a syndrome that has been around since the late 1980s. And this current iteration where it has three prongs, a low energy availability with or without eating disorder, menstrual dysfunctions, and low bone mineral density is the iteration that came out in 2007, and then it was refined in 2014. So the central tenet of it is that prolonged low energy availability leads to an amenorrheic state, estrogen deficiency, and dysfunction of other hormones such as cortisol and leptin, which are required for proper bone health. And then there's a compromise in the bone mineral density. The female athlete triad is a well-known risk factor for stress fractures. The risk for stress fracture with one single aspect of the triad is approximately 50 to 20%. And this risk can increase from 30 to 50% if the athlete is presenting with multiple aspects of the triad. Next slide. The key issue with the triad and the spectrum, and the reason why it has been so widely adopted, is that there's room for the athlete to constantly improve or regress on the spectrum, and the physician can continue to track how this is going. It is an ongoing clinical entity for many athletes. Some don't completely come off the triad and identify as having at least one aspect of it still going throughout their career. Some of the common terms that the triad has well defined is what is energy availability. So this is dietary intake minus your exercise energy expenditure over your weight in your free fat mass. Disordered eating is defined as abnormal behaviors. A lot of us are very familiar with these from the DSM, but restrictive eating, fasting, skipping meals, using laxatives, diet pills, diuretics, overeating, binge eating, purging. These might not meet a strict criteria of a formal eating disorder. However, we know these behaviors to be disordered and they should be screened for, and the practitioner should have high vigilance to ask about these. Oligomenorrhea, as we know, is infrequent menstrual cycles, but when there's an absence of 3 consecutive cycles, we call that amenorrhea. And low mineral density in this age group is really defined by the Z-score. So comparing the results of a Dexa to an individual who's both matched in age, race, and sex would give you your Z-score, as opposed to the most common T-score, which is matched to a 30-year-old. For example, on the spectrum, an athlete with functional hypothalamic amenorrhea on the menstrual function spectrum may slowly return to eumenorrhea. However, the bone mineral density may be still suboptimal and may lag behind for even a year. we want to continue to track the athlete in all three of these aspects to make sure that their health is being monitored while they recover and while they return to sport. Next slide. Breaking down the energy intake just a little bit in more detail, a study from Loveless in 2017 had showed that a reduction of energy availability, even below 30 kilocalories per kilogram for a small period of time, in this study defined as 5 days, was found to slow the normal pulsatile release of luteinizing hormone, affecting negatively the gonadotrophic releasing hormone and slowly affecting the luteal phase, eventually leading to menstrual disturbances. So this is not something that has to be brewing for months and months and years, but it can take a turn for the worse for a female's reproductive health. If we give it a simple example of a dietary intake of 2,000 kilocalories, which might sound like a very appropriate amount that an athlete should be consuming, with an energy expenditure of, say, a 600 calorie workout per day in a 51 kilogram female, so that would be someone who weighs about 112, 113 pounds, this athlete is already experiencing a low energy availability of 27 kilocalories per day. So if we start to see the athlete drop below 30, we start to wonder and worry, are they receiving enough nutrition? Do they have enough energy available per day to continue their workouts and maintain their health? We're going to for sure be getting more into the details of nutrition as we speak with some of our panelists. I want to talk about why we choose the female athlete triad, and there are some comparable syndromes that have been published, and I just want to break down some of the comparisons between them and some of the merits of the female athlete triad. Next slide. So one of the more common ones, and I would say in the early 2010s, there was a big push to replace the female athlete triad with the syndrome known as the relative energy deficiency in sport. This was put out as a position stance by the International Olympic Committee. And it does cover a very broad array of physiological and performance outcomes for both men and women. And it's trying to be more inclusive and discussing how the research also needs to focus on racial differences and disability differences. Both the Triad and the Red-S do call attention to how important adequate energy is to resolving these issues to prevent negative outcomes from getting worse when someone is participating in exercise. However, and this is a soft call, but there's been sort of like a sway back in the pendulum of scientific thought that we really need to keep the focus on girls and women. They are the ones who have the most severe medical consequences and they need the most attention. So really the triad gives the justice of who's at the most risk for this problem. So, you know, you might not agree with that, but the Red-S syndrome objectively has not done a very good job in scientific rigor with quantifiably defining what their measures are and how you would achieve their outcomes. So a lot of people have continued to follow the triad. We are not foregoing it for Red-S at this time. And Red-S could be considered more as a concept as opposed to a medical syndrome. All right, next slide. Okay, so if you're in the office and you have a first pass at this chief complaint and your ears are tuned to possibly this might be somebody on the spectrum of female athlete triad injury presenting with a stress fracture, some of the questions which have been, validated are asking the athlete that day, and we do this, often in a pre-participation physical exam now in the preseason. But have you started having your menstrual cycles? When was your first menstrual cycle? As we know, the older you are, the higher your risk is for having low bone mineral density when your menses starts. How many periods are you experiencing in a 12-month period? Are you taking any hormonal support? And if you feel like some of these questions might be sensitive, you could ask in a one-on-one environment without other people there. But do you worry about your weight? Do you have restrictive habits when it comes to eating? Are you on a special diet? Do you avoid certain foods? Do you like to eat by yourself? Have you ever been diagnosed with an eating disorder? Have you ever been diagnosed with stress fracture? So questions that can, uncover a lot of useful information. Along with that, since there's no one specific blood test for functional hypothalamic amenorrhea, the condition is usually diagnosed by excluding other causes of amenorrhea. So commonly it would be asked to provide a pregnancy test, draw labs for FSH, LH, and look at the ratio of these two. We want to rule out such things as PCOS. Draw a lab of prolactin. The athlete should not exercise prior to prolactin, as it can give you a falsely positive elevated rate. And also check their triiodine, their free T3, and their TSH to see if this might be causing problems to their HPA access. Next slide. All right, so who would require a DEXA scan? So we're not talking about the older postmenopausal age group. We're talking about among athletic premenopausal women and children. Any athlete with one or more of these risk factors would be warranted to have a DEXA scan. A diagnosed eating disorder, a body mass index over 17.5, or low weight, menarche at a later age, oligomenorrhea or amenorrhea, prior stress fractures, a Z-score less than 2, and when we take a DEXA, we really want to make sure that we're getting an AP of the spine or the femoral head neck. We shouldn't be taking it from the greater trochanter or the transverse process to make a diagnosis, and if possible, to avoid the upper extremity as your DEXA scanning source. Okay, so what I'd like to do is, now that we've discussed some of the diagnostic tools that you can utilize to uncover a bone stress injury, I want to discuss the stress fracture rehabilitation. If we could hear from one of our athletic trainers, if you would walk us through, for example, a protocol for using a zero gravity treadmill and how we would rehab somebody with a stress fracture who's in season.
Yeah, so I guess, first of all, it just depends on the type of athlete. So this instance, if we're talking about runners, depends what season they're in. You know, if we're in the spring or in the track season, we kind of have to take a step back first and look at where we're at in the season, because a lot of times a stress fracture is a lengthy process, and especially for distance runners, the progression back is often pretty lengthy, because we want to take our time and make sure not only the fact that we're not going too fast, but also everything's okay from the nutritional and mental health side as well. For the Alter G, when they get to that point, when they get the okay from the physicians to begin progression back to activity, along with other rehab exercises, we generally start them on a 4-week program. And as long as everything goes all right, usually by the 5th week, they are back to beginning running on land. But for the Alter G, we generally start at 50% body weight 2 times a week, and then we increase by 10% weekly. So that's generally a 4-week ramp. And then we usually alternate between steady state cardio and interval workouts. And when they're first getting started, we usually go with a 5-minute walk to get used to the Alter G, followed by a 10 to 15-minute session. When we're just starting out, it's usually a 20-second on, 40-second off type of interval, and then we work our way up to more longer durations. And we, beginning, if they need it, we'll do, incline walking for more cardio, or if for some reason they've developed an extension lag through whatever they've had going on. We'll do walking in reverse. But we tend to keep an eye on really the entire picture while we're doing this, protocol in the Ultra G. And then when they're ready to get back on land, that's when we start, looking at how many miles they're running a week, and then kind of work backwards from that and start them at a low percentage, and then, work back up over a few weeks to being on, when they're running full weight bearing.
Jen, so if there are any attendees who aren't that familiar with what the Ultra G is, can you just sort of discuss what are the pros to using it and how do we utilize the science of it to our benefit?
Yeah, so the Ultra G is just it's one version of a anti-gravity treadmill. There's different versions. I believe in our facility we have one called Boost.
Just can you advance the slide? I just want to show the picture so some people, yeah, great, thanks.
Yeah, so what happens is the athlete gets in a pair of shorts and kind of gets zipped in, and then it kind of becomes this, fun, spacey type where we can take off gravity from them so that they feel they are kind of full weight bearing, but it's taking kind of some of their body weight off, so it's not as hard of an impact. And it's great to use for, not just stress fractures, but we do a lot of, our post-surgical cases, even people who are just, were non-weight bearing and are beginning to progress back because, you can still get a cardio workout, keep up your cardiovascular fitness with it, but it also allows us to, they can work on their gait. They don't, they're
why would you prefer this to water running? What are the benefits of this technology?
They can, well, one, we can see them better. Some water running, the treadmills, some of them you can go down and look at how they're running, but some you can't. So a lot of times you have to trust the athlete, and with the water, with the resistance, and you can't always control yourself in the water as much as you'd like. So sometimes we've noticed, altered gait patterns, their striking has become affected, exactly. And that creates problems longer down the road because now they have to relearn how to run, where they're striking, and so on and so forth.
Yeah, I think that's absolutely right. I think that if we have access to it, which is the nice part about working in the Robert Wood Johnson system, with access to it, the athletes can utilize this to their benefit, like you said, not only for stress fractures, but also for other lower extremity injuries where we want to do partial weight bearing.
Yeah, and I think it absolutely helps as well from, the mental side, them seeing that they're getting back and doing something what they consider to be active, running, walking. It kind of creates, momentum and encouragement for them. So that can really kind of help revitalize their, mentality towards the whole rehabilitation process.
Absolutely. I think that's absolutely right. And if you see like, oh, well, if it's good enough for LeBron James, then clearly I'm getting a special treatment because I get to use this technology too, right?
Oh, yeah.
Yeah. Okay, great. So I think that's beautiful. That was wonderful. One of the things that a lot of practitioners often will worry about is, should my female be on medication to help with the menstrual cycles? And Dr. Krystofiak, I know you're an expert on this. Why don't you walk us through what does the science say about oral contraceptives and bisphosphonates and what we would advise our athletes with the current literature?
Sure, thank you. So this is, again, this is extremely tough topic. I think we can all agree we're still at the really the early stages of truly understanding where this is all at. The idea of low energy availability is so critical, and it's really the foundation about what's happening in these athletes, or even the weekend warriors. So a lot of the times when you're looking at someone who's in an oligomenorrheic or an amenorrheic state, a lot of the focus usually goes into let's try to regulate the menses back to normal as quick as possible. So a lot of people just automatically shift to like, hey, let's get them on an OCP, an oral contraceptive pill, and let's just try to fix one portion of this triad that's occurring. The problem that can occur with that is you can actually start masking some of the effects that's really going on. So you start to not look at overall energy availability as being poor as a really important factor which driving some of these forces. And you can pretty much, in some people, start an OCP and menses can actually return back to normal. And that can give a really bad false sense of security because you're like, oh, I haven't had a menstrual period for a year. I took them, now I'm taking the OCP, and now I finally have a menses again. Things must be getting better. But really, what's happening is that you're not changing the underlying effect of low energy availability. Now, that becomes a little bit of a flywheel effect because now you have low energy availability, you have menstrual irregularities, now you're getting low bone density issues, you're getting stress injuries. So a lot of the time, people are presenting to the sports medicine office and we're picking up on the first effect of this as being a musculoskeletal injury. But really what's happening is that there's multiple things that are happening before that even occurs with, again, low energy availability. So increased physical activity to relative low dietary consumption, whether it's disordered eating or not, whether it's done on purpose or not. And that is, again, causing a downstream effect. So a lot of the time when we start looking at these athletes, we really want to take a step back, not just throw medicines at them. And we want to actually start looking at their training loads. We want to look at their dietary intake. We want to figure out if they're restricting, if they're low in calories, if they're doing too much. And we really want to fix that portion. Some of the literature can look at, you know, really, says like, hey, let's get their weight up. But what they found is that just by getting someone's weight up, it actually does not just normalize bone mineral density so fast. That can take, as Dr. Ashraf mentioned before, that can take years to reoccur. So the resumption of a normal physiologic production of hormones based on these estrogen dependent factors is really what's crucial first. So we really want to start doing that first before we start throwing medicines on, specifically for the OCPs.
Absolutely.
For bisphosphonates, another thing for the for low bone mineral density, again, that's not treating the underlying problem. The underlying problem is low energy availability. So looking at that first is what we normally start with.
Yeah, I think that's absolutely right. And I would agree with you as a practitioner. I think we've generally all moved away from that and given more education about why we're no longer interested in just seeing a menstrual cycle, correct?
Exactly.
Yeah. So I mean, we know that around age 18 and 19 is when you're laying down a majority of your bone, and then you have another decade after that to complete your bone mineral density abilities. And so I think a lot of people get worried that, well, that window of when they are able to lay down bone, they've compromised themselves so much. The other issue I think sometimes with bisphosphonate is if you are prescribing it and you're on it and then you are planning to have children in the future, that could be dangerous for a reproductive age woman, right? The bisphosphonate can stay in the body system. So we definitely want to provide oral contraception for the goal of not getting pregnant, but not for the goal of seeing the menstrual cycle come back. We want to provide energy to improve bones, but we don't want to provide just a medication just to get the bones to falsely look elevated. Is there anything else you'd like to add about this topic, since I know you see it a lot as well, and you take care of a lot of athletes with fractures?
Yeah, I think when it's interesting because when they initially present and you're again so focused initially on that MSK portion of it,
The
whether
tip
you're
of the iceberg, right? Yeah.
exactly, you're
Yeah.
just starting it, and what normally happens. I think you brought up a really good thing about first pass, because that's something that actually a lot of us sometimes do poorly because we're so focused on the MSK that usually it takes a visitor to go and really dive deep and really understand about what's happening because and I see this all the time you're in a physical and, things are going really fast and, say, oh, your menstrual periods are normal. And they're like, yeah, they're completely normal. And then, okay, and then some people can just move on, right? What I do is I take a step back and I say, well, can you explain what is normal to you? And I think that's such an important question because the answer I normally get actually is, well, what's normal for me is I don't have a menstrual period. And that's okay. Well, that's not normal. So we need to now dive further into the questions that you listed before to understand more. Or they say, well, what's normal for me is that I get a menstrual period every other month, or during training season, I only get it, I don't get it, right? So that it's such an interesting question because if you're not asking very specifically, how often is it occurring? What is the ratios? Is there any disruptions? What is the bleeding pattern? Are you on any other medications? You would be really you're missing so much information. And again, tip of the iceberg. And whenever I ask, are you on an OCP? I always follow it up with, well, why are you taking? Is it purely for true contraception? That's one thing, and that is an answer you get. And they say that their menstrual periods are normal, but what can happen is you notice they're on an OCP, and then they say, oh, well, it's because I had abnormal menstrual periods. And then it goes into, yeah, during that time I was exercising a lot and I had like 2 stress fractures. And then you
Yeah.
find out that they never had a bone health evaluation.
Yeah.
No one's looked at their vitamin D, their calcium, or a Dexa. So you get a lot of information from a very short, easy question.
Absolutely.
And it's such an important screening tool whenever you're dealing with these issues.
Absolutely. I agree with you completely. I think you really hit some of the really important topics when the practitioner is trying to decide how to, best start this big issue that they're just uncovering. Jen, if we could advance this slide just to one more time to nutrition. I want to hear from Ms. Salomone, our director of sports nutrition here, about the difficulty of getting energy up, whether they are resistant or whether they're inadvertently not eating well. Like, how do you handle that, please?
That is a loaded question.
That is a very difficult question for you, yes.
But I would start with, at every initial meeting I have with them, I go through a lot of the things that Dr. Krystofiak just mentioned. We go through their bone history, their past history of lab work, disordered eating, eating disorder, current weight history from middle school, really, because that's when disordered eating kind of starts. So I try to get what is their normal weight and what they consider is the weight that they should be at. Because a lot of them think that they want to stay at that freshman high school weight, and little do they really understand is that a female's body continues to grow throughout college. And getting them to be okay with that is becoming increasingly difficult. So we'll go through their dietary habits, seeing their meal frequency, their pickiness, allergies, avoidance, intolerances. We'll calculate their calories from a 3-day food log and determine their energy expenditure to determine where their energy is really at. On the screen, it does say you want them to be more than 45. It is hard to get a lot of athletes to be at 45.
But would you say your goal is more than 30?
Absolutely.
Yeah.
30 is where we see your period basically disappear. So I asked them a lot of questions about their period when it first started. How did they define a normal period? Its frequency, duration, intensity, their PMS symptoms, their birth control, the type of birth control, how long they've been on birth control, and why. Like Dr. Krystofiak said, asking them why is one of the most important questions, because a lot of time I hear I was put on it because I didn't get a period. I'm like, okay, well, that's probably our first issue is why didn't we get the period? Have we been checked for any of that? Is that in your chart anywhere?
Mm-hmm. Yeah.
And then we'll go into their 3-day food log for their calories, their calcium, vitamin D, magnesium, vitamin K, and protein to check all the nutrients that influence bone health. And I take all of that information to turn it into recommendations.
Perfect.
So when it comes to weight, it's very common that a bone injury is caused by someone being restrictive, either intentionally or not. A lot of times we'll get freshmen that come in and they don't understand that they need to be having 4,000 calories a day and they're used to 1,800. And for some reason, a lot of athletes think they should have 1,500 calories and that's good enough for them. So it is an uphill battle to get them to understand that weight and body composition are not performance indicators. Weight is a very small piece of that puzzle, and educating on nutrient timing, diet quality, and hydration. And that's just from nutrition standpoint. There are a multitude of factors outside of nutrition, but all that plays a bigger role than just what your weight is, that number on the scale. So when someone comes into my office and they are underweight or they're scared of gaining weight, we have that conversation about, if you didn't step on the scale today, would you know how much you weighed? And a lot of the times I get no. I actually stepped on the scale today and the number was larger than I thought it was because I felt lighter today. So we talk about, all right, you're feeling lighter, you're feeling faster, you're feeling more agile. How would you say that is more important than that number on the scale? We talk about how we kind of debunk the scale, basically saying if you moved your scale from your kitchen to your bathroom to your living room to outside, you will get a different number each time because your scale is influenced by the ground that it is on. So we do a lot of debunking there and focus mostly on that healthful relationship with food. So when I ask them about their food frequency, their avoidance, their intolerances, I ask them, okay, do you have has it been diagnosed? Have you been checked for a lactose intolerant? No, I just feel like I have terrible bowel movements when I eat yogurt. And it's like, okay, well, let's talk about the other components, because typically the biggest things they avoid is gluten or dairy. When they avoid dairy, that's a bigger risk for bone injury.
Absolutely, yeah.
So,
yeah, makes perfect sense.
yeah, so our biggest thing is that we focus on that healthful relationship with food, and we do a lot of counseling on improving that body image of them and what has been impacting it. A lot of them say they're afraid to gain muscle mass because they don't want to look bulky.
Right. So some of these, and some of these sports that really emphasize leanness and the aesthetics of the sport, it's really difficult. I'm sure, like you're saying, it's an uphill battle to try to convince them otherwise. Yeah. So it sounds like you have a lot of really good tools. Any other pearls that you could share with us about how to make it a successful relationship?
Teaming up with your sports psychologist on a lot of it.
Perfect segue.
And making sure that everyone is on the same page. We're all providing that same message. I think that's very important, and not even just for the athletes, but you're being able to speak in front of the coaches so the coaches can relay that same message. I've had athletes come to me that are 8% body fat, and a coach has told them that, oh, you look big today. And they're like, now I need to lose weight. You're 8% body fat. Please do not try to restrict.
Yeah.
So making sure that you utilize that interdisciplinary team, I think, is the biggest component of it to be successful.
Yeah, great. So Dr. E, I know we have you for a few more minutes. We'd love to hear some of your wisdom on how you handle some of the behavioral components to the female athlete triad, and there's a musculoskeletal component. Yes, there's a nutrition component. Let's please talk about sort of the mental health component and share with us some of your wisdom.
Beautiful segue, Dr. Ashraf and Katie. It's as if you guys, prepared for this for, the last 3 months. So thanks for that. Yeah, I mean, it is all about interdisciplinary work, and none of us can operate on an island. And historically, behavioral health has been on an island because it's been taboo and stigmatized. And so one of the things that we've worked really hard at is destigmatizing any of the challenges or barriers that prevent people from seeking and getting this help. Injury is one of the most common ailments, within any kind of athlete. And so thinking about how that affects them, mentally, there's lots of different mental skills training programs and trying to understand, even, so one of the things that I've done with some of our teams is show some of the physiological images because, there's lots of research about compassion, for different parts of your body. And so if you have a female athlete with a fractured, tibia or something, like, have they ever thought of that? Have they thought of what the bone has done for them? And, it sounds, I always, like, sometimes I'll say, like, this sounds a little granola crunchy, but bear with me, because if we can, the evidence and the research supports that this might have some kind of positive impact. And so if it works for one person, for me, that's an evidence-based practice. So, we work, as Katie said, very closely with everybody. Sports psychology is important in terms of nutrition because it's really important across all of the panelists. And I say that humbly, but that's because we know often where we want our athletes to be, but sometimes just how can we get them there? So if I'm a trainer and I'm pushing them to run past somewhere where they're scared, if I push them, they're not going to want to come back, or they're going to come back in a more rigid way the next day. If I'm forcing on them, medication, this is where something like motivational interviewing is a very general adjunctive language that I think we all should have. And I say it's adjunctive because it's not meant to be its own entity. It's meant to be adjunctive to whatever we're doing. And I think, many residency training programs that I've worked with or trained, we have to integrate that into our language.
Yeah, I agree. How do you best utilize social support, and how often are you seeing them, and how do you get them to have like peer support or family support so they can tackle the issue as it's difficult to do by themselves?
Yeah, I mean, all of this is multifaceted. So it's about, that's why, while psychology has advocated as a hard science, we are, right? We used to be called a soft science. We're now identified as a hard science, whatever the hell that is. But it's still an art, which is what's a bit different than some of the other sciences. And the art is, how do I encourage people to engage? And that it's really eclectic. So some people have better social support than others. Some people don't know their parents, and so, or have a trauma history that's also going to affect their recovery. So how can I understand that role? So it really becomes about like getting to know your athlete beyond just the fracture, for example. And that takes time, right? I mean, that's like bedside manner, and the more data you could collect, the better we can treat somebody. So we do things like injury support groups, and so for all injured athletes, there are support groups for them. And for any of the attendees that might think, well, that's costs money, or we don't have sports psych, or we don't have nutrition, getting creative with the resources. And one of the things that I think is great about, say, RWJ, Rutgers, the relationships that we have, is that there's lots of researchers around us and lots of great institutes. And so utilize them, tap into them. At my school, we have like 16 specialty clinics. And so can we utilize the resources so that we might not have to pay for it, but maybe we could have students coming in that are in training programs. And so just trying to think about ways, and, lastly, like, Bronfenbrenner, or just thinking about the multiple levels of a person, these basic sort of theories that are out there. And all of that is required for an athlete to heal in the most, productive, effective way.
Yeah, I love that. I think that's great. I think support groups is a great way where you could band together a community without a lot of resources, and they can all help each other.
That's right.
Is there a lot of data on, like, you talked about trauma? So is there a lot of data on like adverse childhood events and eating disorders, or later in life, these sort of behaviors?
Well, it's like another multifaceted question, because it's like you mentioned like injury, trauma, and eating disorder. And so there's really nothing linear in behavioral science. So could there be, there's no research that I'm familiar with that would highlight all of that together, and in fact, so trauma, and also trauma doesn't have to be childhood. Like there's trauma. Well, we're living in a traumatic world, off many, if any,
High stress.
on many.
Yes.
Well,
Yeah.
Well, stress, and then if you mentioned about the racial discrepancies and differences. So thinking also about the racial pandemic, and just even if anyone saw, these hearings that are going on now, and seeing some of the videos of some, anyway, we're just surrounded by a lot of intense emotion. That in and of itself can be trauma for many people's brains.
Yeah.
So there's definitely connections for all of that.
Yeah. Okay, great. I love that. I think that's a really good place for us to conclude the panel, but then also give opportunity to hear from our audience if people have any questions. maybe Jess can handle that.
Yeah, Jess is looking right now. I think we did have a question or two. Can't see it.
It was just a
Okay. All right. I think it was someone commenting on a tech issue. We thought it was a question.
I do see one from Jamie Hand. Can I read it out?
Yeah, absolutely.
How do you navigate working with a coach that encourages female distance runners to practice toxic culture? For example, eating less to stay lean, not taking birth control because it quote unquote makes you fat. Thank you, Jamie. Do we want to have maybe Dr. E handle the relationship between eating and performance?
Yeah, so just really quick, there's the coach, I think. One of the biggest things, if also think about Bronfman Benner and all the multiple systems that are involved in the one athlete. For me, relationships are critical. And so I spend the majority of the time building relationships with the coaches, the staff, and all of our providers. So if you have that relationship with the coach, you can more easily give them the feedback to say, this athlete probably, like, you could encourage along, help them to a place where maybe they won't be so strict around what they're expecting that person to eat.
Yeah. Okay, next
And
question.
then I always would encourage them to see the nutritionist.
Yeah, absolutely. Yeah. And then there, there definitely can be some physician education on what birth control can and cannot do and how much weight we typically see, whether that's water retention, and then that sort of normalizes after a few weeks or a month or so. And so not putting so much of the negative implications of eating or taking medication on and putting it into perspective. We have another question from Sydney. At what point do you decide to initiate?
Dr. Ashraf, can I interject?
Yeah, please,
with
Jen,
that
please.
question?
Yeah.
On the athletic training side, I think because, like, as an athletic trainer, like, I work with my coaches every single day. So when a coach is kind of encouraging that toxic culture, I think it's important for you as the, sports medicine liaison and the person that sees these girls and works with coaches or every single day, that you are able to have an open line of communication to be able to, sit down with the coach and kind of educate them. Because a lot of times I find when coaches are like speaking like that and encouraging that, it's because that's how they were taught, in 1970 and 1980. And, they think that's how it is, but, you sit down and you show, negative implications and what it can result in. And a lot of times they just don't even realize that they're, doing more harm than they are good. And, some coaches are open to it, some coaches aren't. And you just kind of have to have that relationship and respect for one another enough to be able to sit down and, talk about it. But I think it's also important to go to the athlete themselves and encourage them that what they're being told isn't necessarily what's going to be the best for them, and that the coach thinks they're helping, but they need to be able to, separate the emotional impact from it that that coach may be having on them.
Yeah, I agree. Yeah, I think sometimes it's intentional, sometimes it's unintentional, but maybe attempting to motivate. At what point, the next question here, at what point do you decide to initiate bisphosphonate therapy? How frequently do you repeat Dexa? So Dexa can be repeated at 12 months if it was abnormal. You really should utilize the same exact machine, again, because you can get different readings. Bisphosphonate would be probably a last resort if this person still wants to become pregnant in the future. So we would probably try vitamin D, calcium, some other options would come first before we trial bisphosphonates in a young reproductive age woman. Hope that answers your question. Has anyone had Alex Stein, has anyone had a case of stress fracture after stopping birth control or after being on it for extended periods of time? Yeah, so there are some instances quite commonly after having a child, which is similar to birth control. So not having your menstrual period for 10 to 14 months, and then having transient osteoporosis. These things can be evaluated. You definitely want to check for secondary causes of the amenorrhea, and then If there are none, then evaluate with a DEXA. That would be totally appropriate. I often see them in the upper extremity, which is not a common location. So then it starts to tips us off to what was going on in the past year and a half or so. Does anyone else want to add anything to that question about stress fractures after birth control? We have one other question. Okay, Mark, my question is why in 2022 are the physicians on this webinar calling athletic trainers trainers? I don't have an answer to that. I guess if Mark, if you are an athletic trainer and you have a preferred title, we would love to use your preferred title. I think the general trend is people can define themselves and we should be smart to use the term that they want to define themselves as. Yeah. I don't mind making corrections if we called somebody a trainer who's an athletic trainer. Sarah Yerkes, has the NJ, and this is going to be for one of the athletic trainers, has the NJSIAA or have you reached out to them about an educational program for all the wrestling coaches in reference to healthy weight standards and the dangers of weight loss? I'd like to hear from one of our athletic trainers on that one.
I believe, hold on.
I can speak to that
Yeah,
because
please, Jess,
I know
go
from
ahead.
the collegiate level, you guys aren't necessarily used to dealing with the NJSAA, but it's
No.
equivalent to NCAA. So I'll jump in. So the NJSAA, you know, with the changes to the weight certification and certainly helping to minimize the amount of, you know, nutritional concerns when it comes to not only certifying at their specific weight each season, but what are their, you know, limits, either, you know, gaining weight or losing weight, certainly has evolved. It has been a challenge for the athletic trainers to keep up, I think, with some of the changes, but you know, in the concept of helping to protect the safety of the student athletes, it's there. But as far as educational programs they do host generally in the fall, typically in conjunction with some of the other organizations about that. But I think where you see some of these old school mentalities, much like the question about the birth control making you gain weight, the old school mentalities are still out there. So it is a struggle to kind of you know, bring people to the forefront of what this looks like. In fact, we just met with a high school AD this week talking about those such needs with their student athletes. And sometimes it's not about what they even want to be able to intake every day. It's what they even have access to. You know, students don't always have access to the best things, or they just don't even understand what are the better choices. So hopefully as athletic trainers, as Jen had mentioned, working with your coaches, when you do have some of those old school mentalities, I think, you know, hitting at your levels will be helpful, and whether or not there's education that goes out to the coaches, that's a whole nother ball game, no pun intended. But thank you for the question, Sarah.
Yeah, thank you so much, Jess, for stepping in on that one. I think we've wrapped up the questions. Yep, I think that's all of it. Great.
All right, well, I just want to jump in and thank everybody that joined us today, Dr. Ashraf and all of our panelists. You did a fantastic job covering this topic. You definitely got me thinking. I have a huge interest in the female athlete, and I learned a lot today, so I really appreciate you putting this together. You all added something really unique to the program. I just want to turn it over to Dr. K to close us up for the day.
Thank you, Diana, and thank you, Dr. Ashraf. Great topic today, and thank you again for all the panelists as well as the participants today. Your questions and feedback are greatly appreciated. Just as a lookout for our next event is on October 7th of this year, October 7th, 2022. We'll be hosting our sports medicine symposium. It'll be on the upper extremity injuries and the competitive athletes. So just to do a quick save the day, we'll have more information coming out in the near future. And happy Summer Friday, everyone, and thank you for joining us. Take care.